next, Dr. Jess Downing. So we're welcoming Jess back. She is a 2000... Dan, are you walking away with the slide advancer? Jess graduated our EM residency program in 2021, and then she did a surgical critical care fellowship at the R. Adams Cali Shock Trauma Center. And following completion of that, we were able to keep her within the system. She's currently an assistant professor in the Department of Emergency Medicine, as well as the program in trauma and critical care at Shock Trauma. She does most of her clinical time in the CCRU, the Critical Care Resuscitation Unit, and also works in the ICU at one of the member organizations in the CAP region. And speaking of the CCRU, Jess is going to talk to us about some catastrophic cases from the CCRU. So please welcome back Dr. Downing.
Thank you, guys. Is my microphone working? Okay. So I'm Jess. This is some of our cases from the CCRU, and thank you to Dr. Winters for my alliterative title. Really, this is story time, so we'll take a little bit of a step back. My disclosures, as Dr. Winters said, I'm UMEM and shock trauma trained, so I have very much at this point drunk the Kool-Aid, and I am still here. And I think that you'll see that throughout this presentation. We're going to talk about some things that are very much shock trauma in the way we do things here that might not be done at other places. But I do also work at a community hospital, Capital Region, or as one of our colleagues calls it, the hospital formerly known as Prince. We have different resources there. And I think that knowing the kind of stuff that we're going to talk about here is applicable kind of regardless of where you work, because these are things that you might want to think about regardless. I'll also mention up front the kind of quality of the evidence for the things that we'll be talking about, which is bad. Like fuzzy would be very kind. Most of these things are pretty unique situations, so most of the evidence can be globally summarized as, we tried this thing for this patient or patients and it seems like it kind of worked. But I don't have any financial disclosures yet. So, clinical learning objectives. We're going to talk a little bit about sources of hemorrhage in post-surgical patients. And we're going to talk about options for hemorrhage control in non-compressible and non-traumatic bleeding. We'll talk a little bit about some postpartum emergencies and hemodynamic support, specifically in amniotic fluid embolism. But what I really want you to take away from this is the idea of being able to quickly identify resources in your department, in your hospital, and in your network and region to help you take care of patients with rare but life-threatening emergencies. And then in that vein, to think about unusual applications for advanced support devices and cognitive frameworks when taking care of these patients. So our first case. This is a 45-year-old male who had a recent kidney pancreas transplant. He was discharged from the hospital about 2 weeks ago. His wife called 911 because he's been weak and tired, and he had 2 pre-syncope events at home. He also started to notice bloody output from his JP drain today. EMS is called. They find him hypotensive. They say that he is cold, clammy with a distended abdomen, and he syncopizes while they're with him, all setting us up for success. When he comes to the hospital, as expected, he is hypotensive, he's tachycardic, he's tachypnic, his pulse ox is okay. You get a quick fast, and it's positive. So you start some blood, and things start to get a little bit better. Blood pressure is doing okay, heart rate's doing okay, his work of breathing calms down a little bit, and he's able to talk to you. Based on your conversation with the patient and the time that you now have to get some collateral from CRISP, you kind of confirm your story. He's 45, he has type 1 diabetes, which led to renal failure, and he's now 15 days out from a simultaneous pancreas kidney transplant. You see that his post-op course was complicated by hemorrhagic shock and intra-abdominal bleeding. He had to be taken back to the operating room post-op day 1 after massive transfusion, where he had some mesenteric bleeding at his transplanted pancreas. They had to redo the pancreatic ojejunostomy. After that, he did well. He was discharged home less than a week later, and he's been doing well at home with his therapy since. Based on this information, Transfer University of Maryland is started. And because, again, he's still doing okay right now, send him through the donut of truth. His CT scan is not really that helpful. It's non-contrast because, as we said, he just had a kidney transplant. His creatinine's not the best right now. All you really see is some free fluid around the liver, which, based on its density, may be blood. And a note that the transplanted pancreas is edematous and amorphous, so may be contributing to the problem. When he gets back from scan, he starts doing worse. He's increasingly diaphoretic, he's pale, he starts writhing around in the bed, his belly hurts, he can't breathe, and then he starts to become more lethargic. Massive transfusion started, pressors are started, patient's intubated, and transport arrives to get him. At this point, he's transported with blood hanging and on a decent amount of Levophed, norepinephrine. So at this point, we know that our job is to keep this patient alive long enough to get to the operating room to get some sort of source control. All of the basics are done right now, right? He's being transfused, his blood pressure is being supported, his airway is controlled. But we know that the basics aren't always enough, and that some semblance of slowing down the bleeding, as we just talked about with GI bleeds, is probably going to be needed to get this patient where he needs to go. We also can presume, kind of globally, based on his history and this kind of unhelpful CT scan, that our source is probably related to his transplants. So let's talk a little bit about the anatomy of a kidney pancreas transplant. Typically, the pancreas is transplanted on the right and the kidney on the left. The kidney, aside from being on the left, is just like any other kidney transplant. The renal artery and vein are connected to the recipient's iliacs, and you're good. The pancreas is a little bit more complicated. A portion of the donor duodenum is taken with the pancreas and anastomosed to the recipient's small intestine to allow for drainage of pancreatic juices. The pancreas has two arterial supplies, so they do an anastomosis to the donor's iliac bifurcation as a Y graft and then implant that into the recipient's iliac. And then the venous drainage can either be into the recipient's iliac vein, IVC, or the portal venous system. For our patient, it was into the IVC. So we know, based on this kind of general idea of how the transplant is done, and our general idea that the transplant is probably the problem, that the patient's bleeding is probably from below the iliac bifurcation. Or I'm sorry, bifurcation. We can't compress that, right? But we know we need to slow down the bleeding. And this is where we can think about what's another situation that you've all dealt with. I see a lot of pink scrubs over here, where you have a patient who's bleeding out into their pelvis and it's more than you can keep up with. And it's in the trauma bay, right? It's with pelvic fractures. And how do we deal with that bleeding? We're not going to put a binder on this patient, right? Their bones are fine. That's not going to help us. But again, we see the pink scrubs. We're in the shock trauma tower, so we kind of know where this is going, which is REBOA. So zone 3 REBOA has become a pretty common part of the way that we manage bleeding from pelvic fractures here. Not everywhere, but here. We've had general good outcomes with it, and we have some retrospective data to back us up. This was a study done from a big national registry of 160 patients who were managed with REBOA plus minus some adjuncts for pelvic bleeding. There are some names there we probably recognize. But again, there's no control group here, there's no standardization, there's no randomization. This was tried for these patients and we think it probably helped. How does it work? Just very quick overview. So arterial access is obtained in the common femoral artery. You hear us harp on this a lot in trauma. It's important that it's the common and not the superficial. If you end up in the superficial and you put this big sheath up and you take it out, then you end up with another bleeding problem that is quite hard to deal with. You insert the sheath through the access that you just obtained, and you inflate the balloon, the specifics depending a little bit on the actual brand that you use, either in zone 1, which is above the diaphragm for things like traumatic cardiac arrest undifferentiated bleeding or abdominal bleeding, or in zone 3 for pelvic bleeding, generally from pelvic fractures, but may be also applicable to our situation here. And this isn't totally out of left field. There is even worse quality evidence, but some quality evidence, for the use of REBOA in non-traumatic bleeding. This was a retrospective review of patients here, all before this patient showed up, 11 who had REBOA placed for hemodynamic instability for non-traumatic abdominal hemorrhage. The time to REBOA was pretty long. Most of it was zone 1, which makes sense when you look at the kind of sources listed here. Most of these were placed in the OR. I have seen 1 or 2 placed in our emergency department here for this type of bleeding. But again, the outcomes were actually okay. If you look, there was 1 death due to uncontrollable hemorrhage, and when you see that over half the patients were dead when the REBOA went in, that's decent. That study gave us a little bit of an algorithm for how to think about REBOA and non-traumatic hemorrhage. And it's pretty intuitive, and it kind of flows through the ideas that we've already talked about with the patient we're discussing today. Is the bleeding life-threatening? Are they in arrest? Are they responding to resuscitation, or do you need to do more? And if so, where do you think the bleeding is? And that'll guide where you put the REBOA. I'm throwing these here just to show you that there are non-shock trauma publications about this. Although on each of these, there's at least probably 1 author with at least some sort of University of Maryland connection, but it's not something that we only do here. It's just something that we do here, maybe a little bit more than other places. So let's talk about our patient getting to the CCRU. He lands at 8:43. He's not doing well. His belly is rigid, it's distended. He has what we're going to call difficult to palpate pulses, which means either dead or about to be, and he's on a good amount of pressors. We get femoral and arterial access, start transfusing, massive transfusion through a warmer, and put up a REBOA sheath given his hemodynamic instability. It doesn't specify here, but it was placed in zone 3. The balloon's inflated, and you don't need pressors anymore. You can even give the patient some sedation, some analgesia, and you get him off to the OR. He's gotten some blood while he's been there, but not enough that you would go from what you had to moderate to off vasopressors without the REBOA. I want to highlight the times here. He came in at 8:43. REBOA is up at 8:53, and he's in the OR at 9:01. I want to highlight this for a couple of reasons. One is, this is pretty fast, and this is what the CCRU is really good at. We have a team, it's a small team, we work together a lot, and we have good communication that lets us get things done quickly for quick resuscitations. But also, we talk to the rest of the hospital constantly. That's probably our biggest job. So we can get someone from the door to the operating room in under 20 minutes because of that communication that's early, it's multifaceted, and it's constant. The other reason I want to highlight time is because that's really the biggest challenge with REBOA, is that there's really limited times that you can use this. It's essentially a half-body tourniquet. The minute you put it up, your clock starts. For zone 1, you want to be in an OR for definitive control in 15 minutes, and definitely not more than 30. You have a little bit more time for zone 3. Your target is 30 minutes, no greater than 60. The challenge, I think, is that you put this balloon up and your clock starts and it's a big time emergency, but everything about the patient and the monitor tells you it's not an emergency anymore, right? The patient's blood pressure gets better, their heart rate comes down, they're gonna be easier to ventilate, all the alarms stop going off. Your nurse isn't pressure bagging blood into the patient themselves anymore. So everything feels calm, and it's easy to let that extra time get away from you. When you put this up, you don't leave the patient. You stay there, you see the clock timing. It's like the nurses in the TRU who every minute the tourniquet's been up, yell out how long the tourniquet's been up. You become that person, and you have to be the alarm for the emergency because none of the monitors are gonna do it for you. So our patient goes to the OR. The trauma fellow goes with him. The person who put the REBOA up stays with the REBOA, stays with the patient. They open the midline incision, which is just a couple weeks old, take out a lot of blood, and the REBOA is up, there's no bleeding. You have your hemostasis. Have a little bit of a back and forth, REBOA deflated a little bit, and they find bleeding from the pancreas, the transplanted pancreas, with a 1.5 centimeter defect. REBOA goes back up, and they get all of their local bleeding control. Everything is ligated, and then you can take the REBOA down. There's no more bleeding, REBOA comes out. They ultimately had to explant the transplanted pancreas. But despite that, he did well. Post-op day 1, and remember post-op day 0 was at like 9 p.m. at night, so post-op day 1 is pretty good. He's extubated, pressors are off. 2 days later, he goes to the floor. He started on his pre-transplant insulin regimen because he's type 1 diabetic again, and he goes home. He's come back a few times since, mostly for complications related to diabetes, unfortunately, but he hasn't had too many sequelae from this overall problem, and his renal function improved. That's our first case. This is my dog. I felt like we should have a dog break. She's very cute. So for our next case, we can all get a little bit more panicked because we have a pregnant patient. So this is a 26-year-old. She is 37 weeks and 5 days into her first pregnancy, and it's already been pretty complicated. She had polyhydramnios, she's GBS positive, and she had a large for gestational age fetus. She went into L&D with a headache and some intermittent photophobia. Her blood pressure was elevated, and she was ultimately admitted for induction for preeclampsia with severe features. She had an epidural placed. Everything's kind of going according to plan, but she does still have a lot of pain despite having this epidural in place. And then that night, things start to get bad. Around midnight, she drops her pressure. She becomes unresponsive and starts to have what looks like a seizure. She looks like she's going to get better, actually. Her blood pressure just kind of spontaneously improves, but then she loses pulses. Everyone's called to bedside. OB is there, anesthesia is there, critical care is there. They do CPR, and they get ROSC 3 minutes later. She regains consciousness, but her hemodynamics are still all over the place. And so a few minutes later, she has an emergency C-section. She's intubated, and she started on pressors. She keeps bleeding after her delivery. She started on a massive transfusion. She gets red cells, platelets, cryo, FFP. She gets TXA. She gets her meds, her oxytocin, her additional uterotonics. A JADA device is put in. And the critical care team does a POCUS after she gets ROSC. They see that her EF seems generally okay. Her RV seems a little dilated, but it's working. And she might have a McConnell sign. Let's talk real quickly just about postpartum hemorrhage, because that's this patient's problem right now. This is something that you guys get lectured on a lot. You know this well. We have our 4 T's of our causes: tone, trauma, tissue, thrombin. We have different approaches to each of them, but we're really doing all of those things kind of at once and in sequence to try to address anything as it might pop up. We have a series of medications, all of which are primarily designed to treat uterine atony, and we have our transfusions. And we have some maneuvers. Bimanual massage, which just looks so uncomfortable, being our top one. The next one is the JADA device, which is what our patient had implanted. All of those many, many years ago that I was in school and training, we mostly talked about the Bakri balloon, which is a balloon that's inserted into the uterus and inflated to tamponade. Our OB team has told me that they don't really use that anymore, and I think a lot of other places have moved away from it as well, in favor of this JADA device, which I think is technically a brand name, but I don't think there's another one, so I think I'm allowed to use it. It works kind of the opposite, but also the same as the Bakri balloon. It uses a kind of low vacuum suction to try to induce uterine contractions and collapse the uterus around the device to then provide tamponade, while also then still suctioning out the any blood that's remaining there. And the outcomes with the JADA, there is some data to suggest that it's better than the Bakri balloon. So those are our first 2 maneuvers. We can also reflect again back on the anatomy of what's going on here. We're seeing that most of the things that are feeding our source of bleeding are, again, below the iliac bifurcation. So we might also then think about REBOA. A lot of the data about REBOA and non-traumatic bleeding is actually about obstetric emergencies. And we actually have a team here for the placement of REBOA for patients with known or suspected placenta accretia. But that's not what we're talking about right now. This patient didn't get a REBOA. She went to IR. And we'll see if I can play this. She went to CT scan and was found to have some active bleeding there along the left side of the uterus. She went to IR, where she had a pelvic angio, and she was embolized. She came to the CCRU after IR, but she still wasn't doing very well. She was still bleeding, but not very much. She was on a lot of pressors, and she was requiring pretty rapid up titration of those pressors, more so than would really make sense with the much smaller amount of bleeding that she was having, especially given the amount of resuscitation she'd already had. Her ultrasound showed this. And we look back and see that her CT scan, the rest of it from the outside hospital, let's see if we can find it, shows this. So in isolation, the CT could mean a lot of things, right? This patient was altered, she could have aspirated, she got CPR, she got massively transfused. But when we put all of these things together, of abrupt hemodynamic collapse during labor, of our ultrasound findings, our CT findings, and this persistent bleeding despite delivery and the JADA, we should think about one thing primarily, which is amniotic fluid embolism. So this is the second leading cause of peripartum maternal death in the US and the primary cause of peripartum maternal cardiac arrest. It affects 2.2 to 7.7 out of 100,000 deliveries. Globally, that's bad. Our rates are much higher than other developed and even a lot of developing countries. The presentation pretty closely mirrors what our patient had. Some dyspnea, signs of right heart failure, cardiovascular collapse, neuro changes, DIC and hemorrhage, fetal distress. Generally starts during or immediately following labor, C-section, or some sort of intrauterine procedure. And our risk factors include induction of labor, which our patient had, any sort of premature rupture of membranes, trauma, C-section, or placental abnormalities. The pathophysiology is complicated and I think not completely understood, and certainly not completely understood by me. It starts with a placental amniotic disruption that allows amniotic fluid and fetal elements to enter the maternal circulation. Those cause release of histamine and these other inflammatory markers and cause a maternal anaphylactoid reaction with a lot of systemic vasodilation and pulmonary vasoconstriction, and I'm going to get back to that in a second. It also interrupts the clotting cascade, it interrupts fibrinolysis, you end up with DIC, you end up with bleeding, and you end up with uterine atony. The pulmonary vasoconstriction seems to really be the kicker here. This is what leads to death in most of these patients, and it's what really complicates your resuscitation. It's the same process as our other forms of right ventricular overload. You end up with increased afterload, increased stretch, worsening ischemia, worsening contractility, and you go around and around and around. And this is where, similar to how we thought about our pelvic fractures in our bleeding transplant, I want you to think about your other sources of RV failure and your amniotic fluid embolism patient. Because I didn't get this picture by Googling like amniotic fluid embolism spiral. I Googled pulmonary embolism spiral, right? Because that's where we see this most. And that's how you can apply a framework you know to a situation that you may see once. The treatment for amniotic fluid embolism is just supportive care. Aggressive supportive care, but just supportive care. And it should be transient. Most of the kind of pathology that this syndrome leads to and causes, and particularly the pulmonary vasoconstriction, really should last half a day to 2 days. It gets better on its own if you can survive it, I also want to note that this list of recommendations, which I got from the Society of MFM, starts with CPR. So we're not starting at a great spot generally, but we're gonna assume that we get past the CPR and we're gonna deal with our components here. For vasodilation, we have pressors, right? We're gonna be careful with fluids because in addition to vasodilation, we have hemorrhage, we have right ventricular failure, and we have hypoxia. For our hypoxia, we're gonna give oxygen and we're gonna have to intubate. But again, because we have vasodilation and right V failure and hemorrhage, we're gonna resuscitate before we intubate first. For our hemorrhage, this is somewhere where TXA is recommended. Other than that, you're gonna go with your massive transfusion protocol, you're gonna deliver if the baby's still in, and you're gonna use your uterotonics and hemorrhage control methods that we talked about before. And then for your RV failure, again, similar to massive PE or severe submassive PE, we're gonna again be careful with fluids. We're gonna use inotropic support. And I wanna note here, the Society of MFM recommends actually milrinone or dobutamine rather than epi. I typically am afraid to start those in patients who are also profoundly vasodilated in the acute phase. So I typically start for any patient like this with inotropic epi, 0.02 to 0.06, and if everything's going awesome later, then we can talk about the other things. You're gonna use some pulmonary vasodilators. Here we have inhaled epoprostenol. Some places have nitric, and you're gonna stick with your pressors. We did all of those things for this patient when she got here. They were not enough. Sometimes these things are not enough. So where do you go to then? And this is when in the CCRU, it's not always that all roads lead to ECMO, but sometimes all roads lead to ECMO. And this again is recommended by other societies, not just all roads leading to ECMO. The evidence here is, again, very, very bad. Case reports, a couple case series of things that were tried and seem to have helped. It is, again, recommended as a consideration by the Society of MFM when all of your other methods fail. And I think importantly, we have some evidence, bad, but some existing, about the use of VA ECMO in these patients without anticoagulation. Because initially, the hesitance from a lot of these societies in recommending ECMO was that these patients are also bleeding, and the common thought was that if you were on ECMO, particularly VA ECMO, you had to be anticoagulated. And we know that that's not true, particularly in these patients. I want to talk really quickly, I know we're about to run out of time, about your role in ECMO as the non-cannulating physician. This is happening in more EDs sometimes, in more ICUs, and it's easy to get wrapped up in all of the excitement of the cannulas going in, but the role of the person managing the hemodynamics is just as important. If you have time, if you're not crashing on ECMO, this is not ECPR, there are a couple of things that you can do that will make the process easier. Get your ultrasounds in the room, get all of your ultrasounds in the room, apologize to everyone else in your department, but they are yours right now. Get arterial access so you can see how the patient's hemodynamics are changing quickly. You're not waiting for your cuff to cycle. And then get good central access or a really good peripheral IV. If you're getting central access, don't go for the right IJ. It will be taken away. In general, as a rule, if you have a patient that you think is going to go on CRRT or ECMO, please don't use the right IJ. Use something else and leave that open. You're going to make sure that your nurse, who's standing next to the access that you've gotten that's beautiful, has a whole bunch of rescue medications. Fluids, even if the patient seems volume overloaded, they're probably going to need fluids when they go on. Vasopressors, more than you think you need. And then a bunch of calcium and bicarb that's all drawn up and ready to go. While they're cannulating, you're going to watch the patient, and you're going to watch the monitor, and you're going to watch the nurse. And you're not going to watch the cannulation. You're going to watch to see when their blood pressure starts to dip. You're going to talk to the perfusionist to know when they're starting to amp up support, and you're going to make sure that your nurse knows to give fluid and medications while that process is happening. Because it's a rocky transition for some patients. Our patient went on ECMO pretty smoothly. Again, everyone was kind of, the bat call was put out when she got there. Cardiac surgery came, MFM came, and she went on pretty smoothly. And her course went pretty well. Again, this is a transient thing. She was decannulated the next day. Her baby also did well, was discharged home from the outside hospital, her hospital day one. Her coagulopathy took a little bit longer to correct. She had an ongoing transfusion requirement, all medical bleeding, nothing seen on CT to suggest she needed another operation. She had some bleeding into her lungs, prevented vent weaning for a little bit, but she was awake, she was following command, she was interactive. On hospital days 3 and 4, she had a repeat echo that showed pretty complete recovery of her RV function. She went from a TAPSE of 1.2 on the top to 2.4 on the bottom, and that's after ECMO was taken off. She was extubated on hospital day 5. She worked with PT, went to L&D the next day, and went home on hospital day 9. So, takeaways from our story time. It's important to know what you don't know. But it's also important to know what you do know and how those frameworks might apply to situations that you've never seen before. And most importantly, you need to know who you have in your back pocket. We have toys, but we have people. And your most important resource is going to be your phone and your voice and your communication skills to get all of those people at the bedside when you need them. I also want to point out both of these patients did really well, and most of it is because they were resuscitated really early. And that's where the emergency department comes in. All of these spirals spiral. If you catch them early, you can cut them off, or at least temporize them. But the longer you wait, the poorer their outcomes are down the line. So early intervention makes a huge difference. That's all I got.
Thanks so much, Jess. It's some very challenging cases. Let me turn to Eileen. Any questions coming through online?
Yes, we have 2 questions. We have one for those who might be practicing at a community site without any REBOA training. Should they call on their surgeon to try to replace a REBOA, or should they just get that patient transferred immediately?
So that's where the timing becomes really important, is if you can't get that patient to definitive source control within that 30 minutes, you should not put a REBOA up. So the limitation for a lot of community places is less about the REBOA itself and more about that whole apparatus to get the patient taken care of. So the recommendations that I showed earlier actually specifically say that if you cannot transfer the patient to get them wherever they need to be in that time, you should not be putting a REBOA up, because the ischemic complications are going to be harder to manage than the bleeding complications. You just keep transfusing and get them where they need to be quickly.
And the second question was, since there seems to be like a histaminergic response in your AFE patients, is there any utility in treating them as anaphylaxis or using that treatment?
I would probably throw it on. I don't think it would hurt. I don't know.
And then we have one question.
Is there any literature at all on partially inclusive REBOA? Does that improve outcomes at all? Does it extend your time period, or do they just bleed through it?
No, there's definitely a move towards using more partial REBOA, and some of the newer devices themselves allow for that to be done a little bit more sophisticatedly. It can definitely, again, with attention and someone being right there and watching the hemodynamics and watching the transfusions and guiding everything, doing partial REBOA or intermittent REBOA can definitely give you a little bit of extra time or just minimize the damage to what you're doing. But I would say that it's not a substitute for that really rapid transfer to the OR, because that's what you really need.
All right, thanks again, Dr. Downing.